Okay, I don't know that I see a prompt.
Okay, in that case, just go ahead, please.
Okay, I think I clicked accept when I logged into Lisa's. Um, well, thank you, everyone. My name is Mark Gritz. I'm an economist by training. I'm the head of the Division of Healthcare Policy and Research in the Department of Medicine at the University of Colorado School of Medicine. And I greatly appreciate the opportunity to talk to you today about using healthcare claims data for pragmatic sustainability assessments. Before I get started on actual claims data, I want to just advocate for sustainability assessments in pragmatic research for just a minute or so. And so I really would like to encourage everyone that is doing pragmatic research to consider including a sustainability assessment as part of your research program. You know, the primary reason for doing pragmatic research is to understand how interventions, either delivery system interventions or other types of interventions, impact and improve health and well-being in the real world, as they say. And part of that improving health and well-being in the real world means that it has to be a sustainable intervention. And when we think about sustainability, we really need to think about it from multiple perspectives, and that would include, patients. So the intervention needs to be of benefit to the patients. It needs to be looked at from the perspective of providers, and that includes both individual providers as well as clinics and health systems, as well as payers and policymakers in the public. So claims data is an absolute need to understand sustainability, particularly from the provider and payer perspectives. But it's also relevant to patients, particularly if they are going to have some out-of-pocket payments, as well as policymakers and the public to understand if the benefits from an intervention are greater than the cost. So I just wanted to take a few minutes to advocate for including sustainability assessments, particularly financial sustainability assessments. And as I mentioned, claims data are a very useful tool for conducting financial sustainability assessments. So what I wanted to do today, and not knowing exactly where everyone's baseline knowledge is regarding healthcare claims data, is I wanted to first identify some national and local sources of healthcare claims data from both public and private payers in the US, describe the structure and domains of claims data that are available for pragmatic research, describe some general steps for acquiring and using claims data for pragmatic research. I'm not going to get into analytical methods unless someone would like to ask a question later at the end of the presentation, and then also help you understand some of the common challenges and limitations of claims data for pragmatic research. And I do hope to leave a significant amount of time at the end for questions and answers, or if there aren't too many questions, I do have an example of using claims data for the integration of behavioral health into primary care, which is some work that I've been working with a number of my colleagues here at the University of Colorado on for a number of years now. Just to really give a quick high-level overview of the pragmatic research uses of claims data. Claims data is designed, it's collected and processed for the purpose of paying providers for delivering services in a fee-for-service framework. And that's important to keep in mind because it does have some implications for what's included in claims data, how it's structured, as well as some of the quality of the individual data elements. And we'll talk a little bit about each of those as we go through the presentation today. While it is designed for paying providers, it is a rich source of data for pragmatic research, but it's really not designed, collected, processed, or even stored to make it easy for research purposes. There have been a number of private organizations that have started up over the last decade or so, with the focus of their business being taking claims data and making it more useful for research purposes. But those are not well suited for most of our pragmatic research type of analyses that we do as health services researchers. Now, claims data is best suited for measuring healthcare utilization and costs from the payer's perspective, although I do want to point out, and we'll come back to this as one of the limitations of claims data, as alternative payment models start to expand, and parts of payments are not included as part of the fee-for-service reimbursement. It is creating some limitations for using claims data for measuring costs from a payer's perspective. Similarly, claims data does provide a source to measure revenue from a provider perspective, although again, there are some limitations for this purpose, particularly as alternative payment models start to become more prevalent. And while claims data can be used for quality measurement purposes and health outcomes, those measures are really more utilization, aren't really clinical quality or clinical measures. And we'll talk a little bit about that as a limitation of claims data as well. So sources of healthcare claims data. And as I mentioned, some private organizations have started up to provide more access to claims data. Historically, and one of the best sources of healthcare claims data, as well as other data on federal government funded or paid payer, the federal government as the payer, is the Research Data Assistance Center that's at the University of Minnesota. And it has data for both Medicare and Medicaid. So it has historical data going back decades for Medicare, as well as other types of information from Medicare financed programs. And so it provides a very rich data source if you're focusing on Medicare claims and other data. And the website address for ResDAC, as it's usually referred to, is here on this slide. ResDAC has also worked on taking Medicaid claims data and putting them into more research usable formats. They started back in the late 90s with what they referred to as their Medicaid Analytic Extract, or MAX files. That system was in place up until about 2015. They then started, as part of improvements in the data information provided to the federal government from states on Medicaid, they started a Transformed Medicaid Statistical Information System program, or TMSIS. And as that data system rolled out that had more robust data in it, they've created what they're calling TAF files, or the TMSIS analytic files. And those are currently available from 2014 up through 2019. And the 2019 files are preliminary. One of the limitations of ResDAC data for Medicaid is that it is about 2 years delayed in terms of getting the data from states transformed and put into the TAF files. And that's why the 2019 files are still preliminary. Another source of healthcare claims data, again for Medicaid, is from individual state Medicaid agencies. The advantage of the ResDAC Medicaid data is it's nationwide in all states, covers all states, whereas if you work to get claims data from individual state Medicaid agency, it's going to be one state at a time. However, the data from state Medicaid agencies can be a bit more timely. There will be some claims run out times that we'll talk about as a consideration for using claims data, but it is more timely than what would be available through the TAF files generally. Also, over the last decade, there have been a number of state all-payer claims databases that have developed across the country. And information on each state can be found. There's an APCD council, or All-Payer Claims Database Council, that keeps track of where each state is. I believe we're currently over about 30 some odd states that have some version of a state all-payer claims database. Here in Colorado, we have the Colorado State All-Payer Claims Database that is managed by the Center for Improving Value in Healthcare, or CIVIC. And it is one of, in my opinion, the best state all-payer claims databases in the country. They've done a great deal of work in putting together an all-payer claims database for the state. Now, in reality, we should probably refer to these as almost all-payer claims databases, because not all payers are included in state APCDs. There was a Supreme Court decision several years ago that related to self-insured employer plans that are managed, or that are regulated under the Employment Retirement Security Act, or ERISA. ERISA, and it is a federal law that governs self-insured employer provided health insurance. And the most, as you probably know, most insurance, particularly health insurance, is regulated at the state level. And so a state can say, if you're going to provide insurance in health insurance in our state, you should contribute to our state all-payer claims database. There was an employer in Vermont that had a self-insured plan under ERISA that did not want to report their claims data into the state all-payer claims database. The Supreme Court decided that that a state could not mandate that self-insured plans report to their APCD. So there is some variation across states in terms of inclusion of self-insured plans in their all-payer claims database. They are on a voluntary basis currently. In Colorado, I believe our state all-payer claims database now covers approximately 80 to 90% of all covered lives in the state. So it's still, there are a number of self-insured employers that are voluntarily reporting, but it's not quite all payer, so almost all payer. But again, it provides a very rich source of information that includes Medicare, Medicaid, as well as commercial insurance. Obviously, if someone is uninsured, they're not going to have information on their healthcare cost and utilization in these databases, as the sources from these come from the payers. As I mentioned, there are a number of private organizations that have recently been established to provide access to mostly private health insurance claims. So Fair Health provides a national private insurance claims database. The Healthcare Cost Institute is a similar one that has pulled together healthcare claims from a number of private insurers. The IBM Market Scan database is the oldest of those that I'm aware of, that again pulls in data from private insurers. And we'll talk a little bit more about some of those in a minute. There are a number of other emerging private organizations that have purchased Medicare data from ResDAC and Medicaid data, as well as pulling together some of the private insurance claims data into a data source where they will either try to aggregate all of these data together. And so there are many of those. I have not used any of them. My understanding is they are relatively expensive to use for research purposes and might not be ideally suited to the types of pragmatic research that we conduct today. Wanted to quickly just provide a quick overview of the basic structure of healthcare claims data. They come in a number of different data tables. One of the most important is the member enrollment or eligibility data tables. This is where information about individual members covered by the insurance provider is included in the claims data. It's key linkage data element to link together all these other data tables is the member ID. This is where you would find demographic information on individual members, as well as specific plan and coverage information. For example, if the plan provides dental coverage, it would be indicated whether the individual member has the dental coverage or not in the member enrollment and eligibility file. A second important set of tables in claims data are provider data tables. And these are both individual providers as well as facilities and organizations. And since with the enactment of HIPAA, individual providers are required to obtain a national provider identifier or an NPI. This is a unique identifier for both individuals as well as facilities and organizations that can be used to link across different data tables. Then to really get down into the claims data, there are medical claims tables that have a claim number as well as the member ID to link it back to that member enrollment and eligibility, and provider identifiers or MPIs that allow you to link back to the provider data tables. Medical claims tables come with both a header file and a line file, and we'll talk a little bit more about what are in those files later, but essentially the header file is a summary of the entire claim, and individual claim line files are related to specific services that a provider is going to request payment from a healthcare plan for. So, again, in our fee-for-service world that we live in, each line would have a specific and individual service that the provider is requesting payment for. There are generally two types of claims that are in medical claims tables. There are institutional claims. These are generally used for hospitals, but they are also used by federally qualified health centers because of the way that FQHCs, or federally qualified health centers, are paid is on a more of a prospective payment system rather than a strict fee-for-service payment system. And so a lot of their claims come in on institutional claims. And then there are professional claims, which are for professional services by individual providers that are tied to each specific service that they provide. Another set of tables in most healthcare claims data are pharmacy claims tables. And again, these have a key, they can be linked by the claim number, the member ID, and the various NPIs. You know, pharmacy claim tables often also have a header and a line component where the header has information on multiple prescriptions that are filled, and then the line items are for each individual prescription. And in those instances, one of the key data elements are the quantity or days supplied for a particular prescription that's being filled and having a claim processed. And then the last set of tables that I personally have not used very much are dental claims tables, and those are very similar to the medical claims tables, where dental services are paid for on a fee-for-service type basis. And again, you can link those together with others through the claim number, member ID, and NPIs. So just some of the basic structure of the claims tables, either the medical, dental, or pharmacy, is a claim table is going to have multiple amounts in it, and that's both for the header and the line items. As I'm sure you've all seen on explanation of benefits that you receive from your insurer, providers will report the amount they're charging for that service. Now, these are amounts that are generally derived from what is often referred to as the charge master file for a provider. That amount is usually or rarely paid, what is actually paid to the provider. It's usually not, I should say, and rarely what is actually paid to the provider. The claim will also have an allowed amount, and as we know, many of our insurance providers negotiate amounts with individual healthcare providers on how much they want going to pay for a particular service. And the allowed amount is the amount that payer allows the provider to charge both themselves and their members for. Then within those allowed amounts, you will often find a plan paid amount. There will also usually be an amount for the patient responsibility. And then if a patient happens to have secondary health insurance, there will be an amount or often just an indicator that there was a third-party liability for that particular services claim as well. On a claim, again, on those header and line files, there is information on providers or NPIs. And again, there are multiple data elements for the providers. There's the billing provider, that's who is billing the insurance plan and who the insurance plan will be paying. And there's as I mentioned, a National Provider Identifier, NPI, for organizations as well as individuals. And so those are generally going to be organizational NPIs. There's also an identifier for the service or rendering provider. and that is the provider that is rendering the service to the member. And again, that's generally going to be for professional claims, that's going to be an individual provider's NPI, so a physician's or other provider that is certified to bill that particular insurance plan. There are also often in some of these tables going to be a service provider location. As I mentioned, some of the facilities are required to also have a NPI, and this would be the NPI of the location where the service was provided. Some tables also have an attending or supervising provider NPI, a referring provider, and for some of the pharmacy claims, the prescribing provider can also be included in those files. Line items, which are the line files, have procedures in them, and those procedures are reported in using current procedural terminology or healthcare common procedure coding systems, or HCPCS codes that are used on professional claims and institutional claims. Now, one of the key things to keep in mind when you're using claims data is that procedures have modifiers to them that help identify specific services or types of services. So for example, for telemedicine services now, if you're an institutional claim, there's a modifier to the type of procedure code that is attached to identify that it was a service that was delivered via telemedicine as opposed to an in-person type of a situation. There are also ICD-9 and 10 procedure codes that are primarily used on institutional claims, particularly hospitals and ambulatory surgery centers will often use ICD procedures as part of their claim submission. Claims also have diagnoses, and again, it's usually there should be a primary diagnosis identified for each claim header as well as secondary diagnoses. For some claims tables, particularly inpatient, there'll be an admitting diagnosis, and if they're paid on a diagnosis-related group type of a payment model or DRG, which again, a lot of inpatient stays are paid on a DRG, those will also be in the claims table. There are also types of service codes, particularly of importance are place of service codes. Those will identify where a service was delivered, whether it was in a patient's residence, whether it was in a private practice clinic office, in an inpatient or outpatient hospital setting. So those place of service codes are really important if you're trying to identify where services are provided and who's providing them. For example, back to the telemedicine example, for some professional claims, they've been instructed to use place of service codes to identify that it was a telemedicine provided service rather than a service provided in a clinic. Also has some information on claim types, which can be useful for identifying inpatient versus outpatient claims. For some services that are delivered, such as therapy or skilled nursing services, there will also be a unit of service, which are often hours or minutes. And then there are also modifiers to the place of service codes that go into and claim types that are often there in those type of service codes. Some other key data elements to keep in mind are dates of service and paid dates. If generally when we're doing pragmatic research, we want to be looking at when patients received services, not the date that the provider was actually paid. And so you'll want to be focusing on using dates of service, and there'll generally be a beginning date of service and end date of service, which for a lot of professional services in an outpatient setting will be the same day, because it's just a single day that the service starts and ends. For hospitals and inpatient services, those are used for determining length of stay as well. Paid dates are not that relevant for our type of research, but if you're trying to compare your claims to something reported by a state Medicaid agency, for example, they often will report the amount they paid in claims in a month rather than the amount of for services delivered in a month. So those paid dates can be useful for some data quality checks. How much time do I have left? Ooh.
You have 4 minutes left.
Okay. Some challenges, data quality. For example, I mentioned if it's not used for payments, it has some quality issues. So member race and ethnicity is a perfect example that are low quality in most claims data. Attributing members to providers is also a common challenge. Linking multiple claims for an episode of care, and then longitudinally linking individuals who change insurance plans is also a common challenge. As I mentioned, you do need to account for claims run out. That's how long it takes for a claim to get paid and fully reconciled. That's usually several months. Some of the limitations that I mentioned are, do they include all the population of interest? They don't have non-fee-for-service payments, and it doesn't really have outcomes information. And sorry, with this full screen, my clock didn't show up, so I didn't realize how close we were getting. Happy to answer any questions, and sorry I rambled on for so long.
Mark, I have a question. Sean Reed at the College of Nursing. I'm working on a project using the APC data, and I was wondering if you could share a little bit more on how to reconcile dollars or bills that I'm looking at, with some of them with like a negative 9999.99 and things of that nature. Could you kind of share your experience on how you would reconcile those kinds of variabilities?
And that is one of the challenges with claims reconciliation, is that you'll get a negative amount when they've denied a claim that they'd previously paid. Those really do depend upon individual data providers. They should provide some guidance on how those types of codes should be interpreted for their particular database. So the APCD should provide you with an answer. I haven't actually used those, Colorado APCD claims for that.
Yeah, some of the bills come in. You could see where there's corrections, but some of them still end up with a negative $9,999. Just kind of interesting.
Yeah, and those are ones that I usually just ignore. Don't include in the analysis.
Thank you.
And Mike, sorry, the chat didn't show up when I was in my presentation screen, so I wish I'd...
No worries at all. No worries. We're not over or anything, but it is time to wrap at this point. So I'd like to thank you very much, Dr. Gritz, for taking the time. And I'd like to thank all participants. We will be closing this room now, and we invite everybody to take a 15-minute break. And then there will be a plenary session starting at 12:15 Mountain Time, 2:15 Eastern Time. And so in 15 minutes from now. So I'd like to thank you once again, Dr. Gritz, and we will end this session, and we will see you all again online. Thanks, everybody.
Thank you.